Hello, howdy, hi. 8 o'clock on June 1st. Have a fantastic cup of coffee here. Thought I would jump online and see if anybody was out and about and enjoy my coffee. It's been a while since I've done an impromptu Ask Me Anything MS. Wanted to see if anyone in the village was out and about this morning. Hey, Calamity Girl in Pink Meadows. Great to see you. Jersey Shore's in the house. Hey, Kathy, how are you? Brazil is in the house. What's going on, Jesse? Scotland's in the house. Hey, Dad, good to see you this morning. Hey, Angela, good to see you. How are you? It is a beautiful and sunny day out. I'm looking forward to cleaning up my garage. And I thought I would jump on and have a cup of coffee with everyone. I hope that you're doing well. Serbia's in the house. That's pretty amazing. Hello in Bulgaria. Howdy hi in North Dakota. England representing. Minnesota's in the house. This is phenomenal. Thanks for all for being here. Northern Ireland's in the house. Derby, UK representing. Georgia's here. Hey, good morning. Even so it as well. Istanbul, it's hot over there. Good morning, everyone. Aaron Boster here, the Boster Center for Multiple Sclerosis. This is an impromptu Ask Me Anything MS coffee talk. I thought I'd spend a few minutes and say hello, howdy, hi, and see how everyone's doing. Port Clinton, Ohio is in the house. Croatia's in the house. That's amazing. Sunny South Dakota. Oh, Miss Tyndall, that's very kind of you. Switzerland representing. Gosh, there's 52 of you that have jumped online. That's amazing. Welcome, everyone. Sydney's in the house. I love this growing global online community, this village. Calamity Girl asks an important question. So Calamity Girl says, can PTSD affect my MS? So PTSD is post-traumatic stress disorder, and stress worsens multiple sclerosis. So unfortunately, I think that PTSD can impact MS, whereas it's not my observation that stress can create neurological symptoms. I guarantee that stress can make neurological symptoms more intense. The good news is, as we work to treat things like PTSD, like depression, like anxiety, we can minimize, we can improve upon those symptoms. So it is something not to ignore. It is definitely something to address. That's a great question. Thank you for asking it. Chilla Coffee representing. Melissa, thank you very much for that. She writes, really appreciate your videos. Well, I really appreciate you watching them. I started to make these YouTube videos years ago. I don't know if you've heard the story, but I was working with one of my fellows, training someone in MS, and we had a no-show in clinic, and it was my intention that I was going to go over a couple key things with that family. They didn't come in, and so I asked my fellow to hold my camera, and I Ray Charles'd it, and I just talked into the camera and recorded what I was going to say. Uploaded that onto YouTube, and didn't pay any attention to the quality of the film or the video or the lights. I was just talking about MS a little bit, and that started me off on this journey. I now make videos every Monday or every other Monday. I love to jump on and do formal live streams once a month. It's really an awesome opportunity to help educate, empower, and energize families impacted by MS. And so thank you very much for asking that question. It's my full intention to keep making those videos as long as you keep watching them, so thank you. So here's a question from Alex. Alex writes, fresh out of Ocrevus infusion here, they draw blood after the IVs are in. So the way they draw blood matters. So if we put an IV in your arm and we start running medicine in and then draw the blood, that might end up with some spurious results. That could end up with some goofy results. However, the standard practice, at least our infusion teams, is to get an IV in the arm, draw blood off the IV, then start the infusion. And by doing it in that order, we collect the information we need from the blood draw, but we don't interfere with the results. And most importantly, we don't have to poke you twice. I really try to avoid having to poke someone more than necessary. And so as soon as we establish the IV, we draw off of it at the Boster Center, and then we start off with your infusion. That was a really great question. So Jesse asks about something called dysautonomia and tachycardia and multiple sclerosis. Are they connected? Not directly. So when we think about the autonomic nervous system, that's part of the peripheral nervous system. That's outside the brain and spinal cord. So multiple sclerosis really affects brain and spinal cord. If you hit the hypothalamus, which is a structure in the brain, which ultimately can control the autonomic nervous system, indirectly you can have some impact. But that is very, very, very uncommon. That's three varies. And oftentimes, if we're dealing with dysautonomia, it's not coming from MS, and sometimes nature's a little too generous. That's a great question. There's some wonderful questions on right now. So Mish Woon, sorry I said that wrong, asks, this may sound crazy, but is coffee okay for someone with MS? So as I sit here and drink my Java, you guys are having trouble hearing me. If you guys are having trouble hearing me, let me know. Go ahead and put a comment in the chat in case it's too quiet. Can you guys hear me okay? Let me know. Is coffee okay? So I love me some coffee. And it's true that caffeine is a minor stimulant. So it's not like taking an amphetamine salt like Adderall or something like this, but it can help wake you up a little bit. And I don't see any evidence suggesting that coffee is dangerous for people impacted by MS. A lot of folks with MS can have difficulty with sleeping, and you can have your wake-sleep cycles kind of shift, particularly if you're not working day shift. And so we have to be careful about coffee in the late afternoon or evening just because it can be activating and keep us up at night. But I don't see any neurological contraindication to enjoying a cup of Java in the morning. So Even So It As Well, one of our amazing moderators and a MS YouTuber, asks a great question about nanoparticles in the blood for people with MS. And so one of my friends, Dr. Brandon Bieber, who is a phenomenal MS neurologist out in California, he has a great YouTube channel. And on his channel, he recently made a video where he talked about gold nanoparticles. And he was going over some data looking at whether or not it might impact multiple sclerosis. I don't want to spoil his video, but go check that out. He does kind of a comprehensive review. Suffice to say that we're not going to see gold nanoparticles entering into mainstream treatment anytime in the near future. Here's a question from Gus. Ooh, where did the question go? Sorry, Gus. There we are. When lymphocytes come back after Mavenclad, can they come back more aggressive or cause new autoimmune diseases? It does not appear so, no. So let's talk a little bit about this concept of induction therapy. I had a very nice conversation with a family just yesterday in clinic, and the patient had just completed 2 courses of Mavenclad, and she said it felt really weird not to be on a medicine. And so Even So It As Well says that it is really quiet. Okay, how do I make it louder, I wonder? Let me try to goof around with this for a hot second. Not my strong suit, Even So It As Well. Testing, testing, 1, 2, 3, 4. Candy says that they can hear. Marge Lamb asks me to turn the audio up a little bit. Okay, Angela says that I'm speaking a bit softly. I'll be really honest with you guys. I'm not sure how to turn up my audio. I'm not going to quit my day job as a neurologist. If you can't hear me, let me know and I'll try to speak a little louder. It'll be my homework to figure out how to change my audio. Mavenclad and other drugs like Lemtrada are induction therapies. And the way that they work is really weird. They don't block cells like a lot of MS drugs. They don't just kill cells off and keep them killed. What they do is they try to reboot your immune system. And this is really key to understanding why we can give someone a medicine once or twice and then we don't have to give it to them again and they can continue to have a benefit. It's because what you're doing is you're changing the way those cells behave. So in this question, they're asking when the lymphocytes come back. So what are lymphocytes? So lymphocytes are white blood cells, and they're part of the immune system that fights off bad guys. And unfortunately, in the setting of MS, lymphocytes have learned the wrong thing and they can attack you thinking that part of you is a foreign invader, specifically the brain and spinal cord. And so when you take Mavenclad, for example, you drop the B lymphocytes. That's part of your lymphocytes, the B cells, and that includes B memory cells. And of course, these B memory cells have learned something incorrect. They think that your brain is a foreign invader. And when the cells come back, they don't come back the same. Your B memory cells only come back about 13-14%. So you're really depleting or diminishing your immunologic memory. Now, to answer your question more directly, Gus, no, I'm not familiar with the cells coming back to be more aggressive. On the contrary, they come back and they're more chilled out. They're less aggressive. And I think that's really kind of a really cool mechanism. If we retrain the cells to be less aggressive, then they're less likely to attack you. And we can see a durable effect in the absence of retreatment. So when you're using these induction therapies, you're making a change to the immune system, and then the hope is that you have benefit for a long time thereafter without having to be on a drug continually. It's pretty interesting stuff. I love this. So Susan said, I just wanted to share a comment my neurologist made to me. Looked me in the eyes and said, you'll never get off your walker. And I said, hold my beer, watch this. So I love that attitude. Now, of course, we don't want people to be at risk of falling and the like, but gosh darn it, I think that is exactly the kind of attitude we want. And I am very, very hopeful that with some physical therapy, Susan, you're going to show off that you can, in fact, do amazing, remarkable things. Maybe walking with just a cane, that would be super cool. All right, let's take a look here and see what other questions have popped up while we enjoy our coffee. So here's a question from Ian Fay, who says, will Sativex be studied in the United States? And so that big long word there is a formulation of a cannabinoid, a cannabis product, which has achieved it's achieved approval in Canada. And studies in the United States were halted. And so at present, I'm not aware of ongoing studies in the United States, much to my chagrin. So Kat Meyer says, what are your thoughts about low-dose steroids for small relapses? And that's not a style of MS neurology that I practice. The reason that we use high doses of steroids is not because of big attacks. We use high doses of steroids because we need to penetrate into the central compartment. And the concern is when you take 20 milligrams or 40 milligrams of prednisone, it's not adequate to penetrate in the central compartment to slow down the inflammatory activity in the brain and spinal cord. So if I'm going to treat an attack, using something like a Medrol dose pack is not the way that I'm going to try to approach it. So C. Kata writes, what do you think about Kesimpta and the long-term outcome of being on Kesimpta from the disease onset? So Kesimpta, ufatumumab, is an example of an excellent B-cell depleter medicine. These are medicines that work mechanistically by pushing down those B cells and holding them low. The way that Kesimpta, rituximab, Briumvi, Ocrevus work, those are all B-cell depleters, is by disallowing the B cell to piss off the T cell so it goes and attacks you. And as long as we keep those B cells low, then we interrupt the ability of the adaptive immune system to attack your brain and spinal cord. It turns out that medicines like Kesimpta are highly, highly effective in treating MS. Some of the most effective mechanisms that we've ever seen. And what are my thoughts on starting someone off on a medicine like a B-cell depleter and keeping them on it for a long time? My thought is that's an awesome sauce way of controlling the disease. I think that someone who does that is very likely to have a very, very good outcome long term. I think that it's an error to start someone off on a namby-pamby drug, a mild drug, and then only escalate them if they get worse. To me, that's like saying, if you're having unprotected sex and then you get pregnant, well, now you're allowed to use a condom. That just doesn't make a lot of sense to me. I would much rather come out of the box swinging and control the disease early on. And that's not just an emotional comment. The most inflammatory, most significant period of damage is the first 5 to 10 years of the disease early on. And controlling that disease early on is very, very important. And it sets the stage for a much quieter trajectory of multiple sclerosis. Now, if the question was about the long-term safety, I think that the long-term safety is not bad. I think sometimes B-cell depleters get a bit of bad press, and that might be marketing from other competitors, if I'm honest. But I feel like the concerns with B-cell depleters would be risk of infection, and we can monitor for that. So we can check laboratories, as we are wont to do with B-cell depleters a couple times a year. And if we see that the immunoglobulin level, that's a doctor word for the antibody levels, are in normal range, if we see that your absolute lymphocyte count, again a doctor word for part of the white blood cells, if those things are good, then we should not be terribly concerned about the risk of infection. And so I think it's mitigatable. Now, let's see. No stress, no more stress says that they can't hear me, but Sandra P says that you can hear me fine. And again, guys, I'm sorry if you're having trouble with the audio. Bluntly, I'm not sure how to fix it. I'm going to have to figure that out online. If you guys like this impromptu Ask Me Anything MS, do me a favor and throw some hearts in the chat. That's a great way of teaching the YouTube algorithm that you dig this content. And then it helps push it out so more families impacted by MS can benefit. And that's really my goal here, is to energize, to empower, and to educate families impacted by MS. So Paul says that Paul's been on Ocrevus for nearly 2 years and dealt with COVID fine, and I'm really, really glad to hear that. Now, look at that. There's some hearts coming in the chat. Thank you very, very much, guys. That's amazing. Marla Hopkins, one of our amazing moderators and an amazing human being, is showing love in the chat as well. Thank you for being here, Marla. I really appreciate that. This is an impromptu Ask Me Anything MS. I wanted to reach out and connect with you guys and have a cup of Java and answer any questions that might be coming. So Elizabeth says hello from Ontario, Ohio. Great to see you. And Kathy has some strange hearts there, but thank you, Kathy. Marla says, see you soon, and I'm going to look forward to that. So I'm not sure that I can pronounce your name, Chiprav. So I'm not sure if I said that right, and if I didn't, I apologize to you. But the question is, what would you say are some breakthrough therapies or technologies on the horizons that you're most excited or intrigued about following? So I think one of the things that I'm very excited about are anti-CD40 ligands. So that's a really weird word, right? Anti-CD40 ligands. And anti-CD40 ligands are not new in immunology, but they're newly tested in multiple sclerosis. Had to turn up the volume all the way for myself to hear. Good morning. And anti-CD40 ligands are an infusion, which is given in the vein about once a month. And we're starting to test them in the setting of multiple sclerosis. At the Boster Center, we're involved in a clinical trial called the FREXA trial. And it's a trial studying these anti-CD40 ligands. And so those are on the horizon. I'm very, very excited about them. I'll give you more updates as things move forward in time. So Rose says the heat is rising in Florida. Honestly, it's really warm and beautiful outside right now here in Columbus, Ohio. So Kathy writes, why haven't they come up with something to remedy, to go back and fix things that you've lost? So Kathy, I think that would be amazing. And I think that would probably fall in the category of a remyelinating neuroprotective type mechanism of action. Bluntly, in 2024, we don't know how to repair brain damage. And so when there's brain damage or spinal cord damage from MS or from a stroke or from traumatic brain injury, we don't know how to reverse that, which brings out the critical importance of being proactive. We want to use the most effective disease-modifying therapy that you're comfortable taking as an insurance policy against future events, as a seatbelt, if you will, that you would wear to prevent damage in a crash, as a birth control pill to prevent an unplanned event. And the goal is if we can prevent the damage from occurring, you're going to fare much, much better moving forward. Would I love, love, love to be able to reverse brain damage? Of course I would. But bluntly, I don't know that we can do that just yet. So Preppy Pink, fun name, is shouting out from Georgia. Thank you for being here. There's 116 of you online, and that's just amazing. Thank you. I've said this before on this live stream format, but I started this channel just to educate and empower and energize, but I didn't realize that it would help build a growing global online community. And that's what this is, and it's really important to me. And so thank you for being here and supporting this channel. I really appreciate that. A lot of great questions coming in. So Jesse B writes, I saw a post recently about the potential availability of ocrelizumab as an injection. And so it's not uncommon that when a manufacturer develops a drug, that drug has a life cycle, and after a certain amount of time, it's off its patent. And it's not uncommon that towards the tail end of that life cycle, the manufacturer will try to come up with a tweak so that they can keep it on patent in a fashion. And the manufacturers of ocrelizumab have worked supposedly on a subcutaneous, so a sub-Q injection for Ocrevus. And I think that we'll be hearing a little bit more about that as the future moves forward. So we've got Christina from Germany. Hello, it's great to see you, and thank you for being here. So JC brings up, what do those of us that are immunocompromised do with measles outbreaks, which are global now? I can't get an MMR vaccine because it's a live vaccine. I'm protected as my blood show immunity to measles. So really, there's an excellent answer inside your question. Measles, mumps, and rubella used to kill very, very severely. It was a very, very scary time. And by the virtue of developing vaccines, we can help prevent that from occurring. And so the answer is to be vaccinated, and you are vaccinated. If you mount immunity, if we can measure antibodies against measles, for example, in your blood, then you're protected against that, and that's very, very important. And that doesn't go away just because you start a B-cell depleter. There are some great questions in the chat here. Oh, Marla, you're very, very kind. So Candy Duncan asks an excellent question about the way that we construct MS clinical trials. So she writes, can you explain how a trial works when one is a pill and the other is an infusion? So let's talk about that. So when you want to do a Pepsi-Coke challenge, where you're comparing drug A against drug B, it's very important that we do something called maintaining a blind. So we don't want the person receiving the medicine And we don't want the clinician, the doctor assessing the person, to know which one they're on, because that could unduly influence the result. So when you're doing a trial where there's two pills, all right, like pill A and pill B, you make both pills look identical so that the person taking the medicine and the doctor assessing the person can't tell the difference. That's how you do that. When you have a trial where there's a pill and an infusion, then you need to take one more step. And here's how it works. If we're doing a trial comparing a pill and an infusion, we're going to take a group of people with MS and divide them. And this group over here will get a pill and an infusion. And this group over here will get a pill and an infusion. But over here, the pill is real and the infusion is dummy drug. And over here, the infusion is real and the pill is dummy drug. So that way, every person participating in the trial gets an infusion and they take a pill, and they don't know which one is real. Now, one of them is real, but they don't know which one. And by doing that, we maintain the blind. That way, you can't figure out which you're on, and the doctor can't figure out which you're on. And this is the way that we do a lot of clinical trials. For example, I earlier mentioned the Frexa trials earlier in this live stream. And in that trial, everybody gets an infusion in the vein once a month, and they take a pill once a day, and they don't know which one's real. That information is kept secret in a lockbox in Zurich, and we don't reveal which allocation the patient was assigned to until the end. Great trial. Carol from New Jersey says, hello, howdy, hi, great to see you. Even so as well, thank you for being here with us today. I really appreciate you stopping by. A lot of great questions in the chat. I am really excited. We just jumped on here in an impromptu Ask Me Anything. There's 122 of you that have jumped online, enjoying a cup of coffee with me this morning. Thank you for that. Scrolling back and looking for a question or two. I might be able to grab a question pre-planned. Let's switch some things up, guys. This is my river scene. I find it calm and relaxing. I hope that you do too. So here's a question coming from Laura. And Laura asks, what's the best dose of vitamin D3? So vitamin D3 is something that you can get naturally from the sun. So when the sun hits your skin, there's a chemical reaction and your body produces D3. And if you go out in full sun in a halter top for, let's say, 15 minutes, you will produce 5,000 international units of D3, which is about the dose that I find most people benefit from taking. Now, the actual proper best dose depends on your blood level. And so I oftentimes at the Boster Center will draw a blood level of a laboratory called the vitamin D 25OH level. And that level will tell me how much active D3 is in your bloodstream. And it's my goal for my patients to keep them above 50 but below 100. That's the range that I want them in. Based on that level, we can then adjust the amount of vitamin D3 we give them. And so there are patients that have a vitamin D 25OH level, which is 3 or 4 or 10, really, really, really low. And so we are going to give them a lot of vitamin D3 and try to push that level up. If we find out that someone has a level of 80 or 90, whatever they're doing, I love that, and I don't want them to change what they're doing. If we find out that someone has a vitamin D3 level above 100, say 120, that's too high. And then we're actually going to hold their vitamin D. And so I think that instead of having a one-size-fits-all, then I think that it's better to check a level and then sort it out that way. I really, really do. This is a great question from Claire, who writes, Can new numbness in any location stem from an old lesion that's become inflamed? Yes, it can. So just because you have a numbness doesn't mean that it's a brand new thing. It could be re-emergence of old stuff. I know that that's very, very tricky. What else do we have going on here? So Martha says, is there any reason why the MRI mentions the exact number of lesions on the spinal cord, but they say multiple lesions in the brain without giving the number? So in part, that's because there's less tissue in the spinal cord, and there's typically less lesions, and it's more impactful. So one spinal cord lesion can be devastating to someone, whereas a brain lesion, particularly in the top of the brain, may even go unnoticed. I am not inclined to become a lesion counter, particularly in the brain, where we count up each lesion, because once we've made the diagnosis, I'm less concerned with the number as I am the delta, or the change over time. So if you have 100 lesions on your brain, and next year you have 101 lesions on your brain, arguably you have better disease control than someone that has 10 lesions and the next year has 20, right? So the overall number's lower in the second person, but the delta has doubled, and that's very, very disconcerting. So when I'm looking at an MRI with a family and I'm comparing the new scan to the old scan obtained the year earlier, I'm not as inclined to look at the total number as I am to look at the change over time. Also, whereas number is important, the size of the lesion matters, the volume of the lesion matters. And so I think that it's not as simple as counting up lesions. Marla asks, does delta mean size? Delta means change. So not the size of the lesion, but the number of new lesions is really what we want to look at. The delta is the change over time. So Jamie asks, what are your thoughts on hyperbaric oxygen therapy alongside a DMT? And I really like the way that Jamie asked that question. Hyperbaric oxygen therapy is popular in some circles in the setting of multiple sclerosis. And yet the data does not, in my mind, support its use very much. I have not seen compelling papers where oxygen therapy has really had a dramatic impact on the disease. Now, I'm not throwing stones or saying it's bad or saying you shouldn't do it. I'm simply sharing with you my understanding of the literature. And in this question, Jamie says, what do you think about it in addition to a disease-modifying therapy? Well, I think that's probably okay. When I'm considering an alternative therapy, right, a therapy different from a standard allopathic drug, I have 3 rules that I think about. Number 1 is it can't be too expensive. And only your family can answer that question for you, right? So each family is going to have to assess the expense of a given intervention. And so let's take for the sake of this discussion that it's not expensive for you to do hyperbaric oxygen therapy. Okay. The second thing is it can't be dangerous. And we wouldn't want to take a therapy which could put us in danger. And to my knowledge, done safely, hyperbaric oxygen therapy is not dangerous. Number 3, it can't be instead of something that we know works. So we wouldn't want to do hyperbaric oxygen instead of a proven disease-modifying therapy. So in this example, if the hyperbaric oxygen is affordable, it's not taxing the pocketbook, if it's safe, which I think it is done properly, and it's in addition to a disease-modifying therapy, giddy up. Let's do it. And if you find that it's helpful, I'm delighted. But those are the rules that I use when I'm trying to navigate disease-modifying therapy in addition to something else. I'm a big fan of Java. Let's take another peek at the questions. So IM says, is it safe to stop monitoring my B cells before my next infusion? I've been taking rituximab for a couple years. No, it is not safe to do that. When we give someone a disease-modifying therapy, there are certain safety laboratories or safety assessments which I think are critically important. And I wouldn't want to stop doing those. I think that could be dangerous because we not only want to consider the efficacy or the benefit of the disease-modifying therapy, but we need to consider the risk profile. We want to make sure that it's not too risky. And so the way that we monitor with these B-cell medicines is we check laboratories to make sure that the antibody counts aren't too low. We want to make sure that the lymphocyte counts are not too low. And that way we can mitigate the risk of infection. So I would not be inclined to ignore that at all. I think that's pretty important. Let's see here. Some great questions in the chat. I'm looking for one that I can throw up on the screen. I've got my son's cat right here. Let me see if I can drag him over into the video. This is Mewtwo. Mewtwo is a sassy boy. Do you want to say hi to the internet? What do you think? So Christina says, can you say something about breathing problems caused by MS? And so fortunately, MS doesn't generally cause difficulties with breathing. We don't normally see difficulties with the breathing centers. We can see something called aspiration pneumonia, which is a swallowing problem where people swallow down the wrong tube. And that can cause a pneumonia, and that can be very, very serious. And so when someone with MS is coughing, sputtering, choking when they eat, I'm very, very concerned that we got food or saliva or liquid going down the front tube and not the back tube. And that can be very, very concerning. It is less common that you have breathing difficulties with MS, and oftentimes it's not the ability to exchange oxygen. It's not a problem with the function of the lung. It's a problem of the function of the bellows, all right? So opening your chest cavity and closing your chest cavity to help make the lungs work. And there are fortunately exercises that we can do to help with that. You can look up something on the interwebs called an incentive spirometer, which is a little gizmo. It's like a little tube, and there's a suction. You suck in on it. And oftentimes we see them in the hospital. And what they do is they force the lungs to open up, and they can help train the lung muscles, or the rib muscles, if you will, to make them stronger. And so if you're having trouble taking a deep breath, or if you're having trouble with aspiration, we want to not ignore that. We want to address that. And sometimes we need to see speech pathologists or respiratory therapists that can help us with that. So Anatola says, do you believe in use it or lose it? And I do. So really what you're talking about here is the concept of deconditioning. So if you allow a muscle to atrophy, if you don't practice using it, it's not going to get stronger, it's going to get weaker. And so staying physically active, staying as mobile as we can be, is a really, really important tenet to winning despite having multiple sclerosis. Absolutely. So let's see here. Catherine says that her mother-in-law is adamant that parasites are causing MS. How do I respond to her? Wow. So for the record, parasites do not cause multiple sclerosis. And I think there's a couple different ways of dealing with a village member that has an idea like this. One of them is to say, thank you very much for caring about me. Thank you for wanting me to do better. I really appreciate your insights. And thank you for wanting to make sure that I'm okay. I want to reassure you that I am working very closely with my doctors. I'm working very closely with my medical team. And I need you to support me, and I need to allow my doctors to help direct my MS care. That's one way that you can do it. Another way that you could do it, and I'm not saying one's better than the other, is to say, gosh, you know, that's very different than what my doctors, my medical professionals who are trained to help with MS, you know, that's not what they're saying to me. And so if you find a medical research paper which supports that idea, then please print it out, and so I'll be happy to give that to my doctors. It's a tricksy thing, and you don't want to be disrespectful, but at the same time, that's just shenanigans and it's not accurate. I think sometimes people with the very best of intentions are trying to help you, and they may not have adequate education or information, and yet they're trying to do their very best job. So I would hope that your mother-in-law is speaking from a place of love, and she just happens to be misinformed. At the end of the day, I think that we have to just keep in mind that your mother-in-law is not your doctor, and it's not her disease. And we can say, hey, thanks a lot for caring, and then just move on to the next topic and maybe discuss dinner that night or something like that. My coffee is gone. I wanted to jump online today to say hello, howdy, hi. I am so appreciative that you guys jumped online with me. I mean, golly gee, we've been doing this for about 41 minutes, and there's already 157 of you online, and that warms my heart. Thank you to each and every one of you. I created this YouTube channel to help educate and energize and empower families impacted by MS. And it's such a meaningful thing that you support me in these endeavors. It's such a meaningful thing that you jump onto the live streams and that you like the videos and subscribe to the videos. I really, really appreciate that. If you wanted to help the channel grow, you can do that. You can ask village members to subscribe to the channel. You can watch my videos when they come out. You can hit the like button or the share button. And those things are very, very impactful. They teach the YouTube algorithm that this is important content, and that you can help push it out so that more families can benefit. As always, my name's Boster, and I want to thank you for learning about MS with me. I want to thank you for supporting me in these endeavors. I will continue to publish several YouTube videos every month, trying to help educate and empower and energize. I'll continue to do formal live streams the last Saturday of every month. And it was really, really fun to jump online with you this morning. My coffee is empty, and I'm going to need to fill it back up. I'm going to wrap up this impromptu educational live stream, and I want to thank each and every one of you. I hope that you have a great weekend, and I'll look forward to seeing you this coming Monday when I put out my next YouTube video. Take care, be wonderful, and bye-bye.